Hi, this is Nancy Reed. I am doing a lecture series on ophthalmology for University of Lynchburg's Physician Assistant Studies. This is part 9 of the lecture series called Posterior Eye Disorders. All the eye disorders that we're going to talk about in this section, in order to diagnose these eye disorders, you have to do an ophthalmologic exam with either a panoptic or a standard ophthalmoscope. And as discussed in the review section of this lecture series, doing it with a dilated eye is going to give you much better visualization of the back of the eye. So panoptics offer a great opportunity to see even more of the back of the eye, but having a dilated eye helps out tremendously. So we're going to talk about macular degeneration, optic neuritis, papilledema, retinal detachment, retinal vascular occlusion, which includes retinal artery, central retinal artery occlusion, and central retinal vein occlusion. We're going to talk about retinopathies to include diabetic retinopathy and hypertensive retinopathy, and then we're going to finally finish it up with retinoblastoma. And I could tell you guys, you could spend hours and hours and hours on this section alone, especially going over the retinopathy topics with diabetic and hypertensive retinopathies. But we're going to teach you what you need to know for the PANCE, the PANRE, and for clinical practice. Unfortunately, these conditions are typically diagnosed by ophthalmologists, again, because of the lack of dilating eyes in like a primary care setting or an urgent care setting. So the first thing we're going to talk about is macular degeneration. It's the most common cause of permanent visual loss in the elderly due to atrophy of the outer retina. Risk factors for this condition are Caucasian, female greater than male, family history, and smoking. Signs and symptoms include painless, progressive, gradual bilateral central vision loss. So this is a central vision issue, and it distorts the images. And on physical exam, you can see retinal drusen bodies, which are yellow deposits around the macular area. And treatments include anti-angiogenic injections and laser photocoagulation. And on the right here, this bottom picture, this is called an Amsler grid. And with macular degeneration, the image becomes distorted like you see here in the picture. So this is what macular degeneration looks like. Right here on the picture on the right-hand side, you can see these yellow spots. This is considered drusen, and here is the macula. So you're going to have yellow drusen spots that surround the macula. Again, it's very hard to visualize this in a non-dilated eye. Optic neuritis is a sudden unilateral loss of vision, and it is painful with extraocular eye movements. Vision typically returns in about 2 to 3 weeks, and it is associated with the systemic disease multiple sclerosis and viral infections, including measles, mumps, and varicella. And signs and symptoms include loss of color or vision. You can have a relative afferent pupillary defect. And on physical exam, you're going to have optic nerve swelling and flamed-shaped hemorrhages. So these words that you see highlighted, especially on physical exam, again, it's hard to write a clinical question about an eye condition because being able to see in the back of the eye is so difficult without the eye being dilated. So a lot of times in the clinical scenario questions, they will have these telltale signs. So if you see flame-shaped hemorrhage, you automatically want to think optic neuritis. So these red highlighted things are the major takeaway points for the slides. So treatment is IV steroids, you should not receive PO steroids because it can actually increase the reoccurrence rate. So here is the optic neuritis, and you can see the flame shapes coming out from around the area. So that's optic neuritis. Papilledema is a physical exam finding and not a specific condition. You can have papilledema with lots of different conditions, but I put this in here in the posterior eye because this is where you would see this at, but it's not a condition in and of itself. It usually indicates there's something else going on. In optic discs, papilledema is a swelling of the optic disc due to rising intracranial pressure. And it usually occurs bilaterally. The etiology can be a pseudotumor cerebri. It can be tumors, inflammation, edema, encephalitis, and overall the people will typically have intracranial hypertension. So signs and symptoms, they will complain of enlargements of blind spots with or without loss of visual acuity. And so the treatment, you have to target the cause. You can give them acetazolamide. You need to do neuroimaging. You may have to do an optic nerve fenestration or a lumboperitoneal shunt. So you're trying to bring down the pressure, the intracranial pressure, to take the swelling and the pressure off of the optic nerve. So here's some examples of swollen optic nerves, and I hope you can appreciate how enlarged this is and it's bulging. And then again, over here on the right hand side, you can see this bulging disc, and you can see the cup in here as well. So now we're going to talk about retinal detachment. You can have two different types of retinal detachment. A retina can detach spontaneously, or it can detach because of a traumatic event. But signs and symptoms include blurred vision without pain or redness, and they often have associated flashing lights or new floaters. So risk factors include cataract extraction, myopia, older, or history of trauma. And so let's talk about myopia again. Remember, we talked about the eye being too long, and it has excess pressure where the retina attaches to the back of the eye, and it can just peel away or pull away. So on physical exam, if you're dilate the eye, you can see a hanging retina in the vitreous. So here's that hanging retina, and the superior temporal area is the most common area. So treatment is immediate referral, and they either do cryotherapy or photocoagulation. So I would tell people, if you don't like being woken up in the middle of the night, don't be a retinal specialist, because you have to go in immediately and do surgery on these people. So lots of late nights for these guys. Central retinal vein occlusion, or CRVO, and it's a sudden, painless monocular vision loss, often upon waking in the morning. Risk factors include a history of glaucoma, hypertension, diabetes mellitus, cerebral vascular disease, or use of oral contraceptives. On physical exam, the disc is swollen, the veins are dilated, you'll see retinal hemorrhages and cotton wool spots. And treatment is to treat the macular edema with laser treatment or intravitreal injections with VEGF. And severity of the initial vision loss is a good guide to the visual outcomes. So central retinal artery occlusion is a sudden, profound, painless monocular vision loss. If greater than age 50, you have to start thinking that it might be because of giant cell arteritis. And you also need to think about, is there a carotid or cardiac source of emboli being tossed up into the eye? So if like there are throwing off plaque, the plaque can go up and occlude the artery. So you have to do a duplex ultrasound, echo, and an ECG. So risk factors include diabetes mellitus, hypertension, hyperlipidemia, oral contraceptive use, and systemic vasculitis. So on physical exam, they're going to have a pallid swelling of the retina. They're going to have a cherry red fovea. They're going to have attenuated retinal arteries, and emboli may be visualized. You may actually see the emboli caught in the artery. So labs, again, if you think it's giant cell arteritis, you may want to do a sed-rate or C-reactive protein. And treatment for this is emergent treatment. You want to lay the person flat. You want to do ocular massage and high concentration of O2, hoping to potentially knock loose whatever's occluding the artery. You can do IV acetazolamide, and you may have to do anterior chamber paracentesis. If it's giant cell arteritis, you're going to do high-dose corticosteroids and a temporal artery biopsy. And retinal embolism due to AFib or hypocoagulative state requires anticoagulation. So if the blood clot for some reason, you have to start thinking about anticoagulation. So if you look in the back of the eyes, these guys have definite, clear, different appearances. As you see here, you have these hemorrhages all over on the retinal vein occlusion, and on a retinal artery occlusion, everything looks pale and washed out. So diabetic retinopathy and hypertensive retinopathy, again, as I said before, you could spend hours and hours and hours just on these two topics alone. The real big take-home thing that I want you guys to remember is when you're talking to your patients, especially if you're in an urgent care setting or a family practice setting, you need to ask your diabetics and your hypertensive, when was the last time you went to the eye doctor and you had a visual screening, which include dilation of the eyes? So a lot of people will think that you say, when was the last time you had an exam, an eye exam? And they'll say, oh, well, when you just checked my visual acuity. So a lot of people think that a visual acuity check is an eye exam, and it is not. So I would explain to my diabetics and my hypertensive people that they need to have an annual exam once a year where they do a dilation of the eye or an alternative method. They have some new alternative methods where they don't have to dilate the eye, but they can take pictures and map the back of the eye. So the important part is the retina is being evaluated at least once a year. So diabetic retinopathy is the most common cause of new blindness in age 20 to 65. There's two different types. There's non-proliferative and proliferative retinopathy. So non-proliferative, they have dilated veins, they have little microaneurysms, they might have some retinal hemorrhages, some retinal edema, and hard exudates. But the proliferative type is called, they have neovascularization, which basically means that the eye is building new little blood vessels. So you must think, oh yeah, new blood vessels, that's a great thing. Well, it's not, because these new blood vessels are thin and tiny, and they break, and when they break, they bleed, and we don't want that. So that's proliferative retinopathy. So treatment, you want to do a pan-retinal laser coagulation to prevent blindness, and you want to do injections of anti-VEGF, which is vascular endothelial growth factor. So trying to stop those new vascularizations and close those down. So as you see on this exam, you can see all these new little blood vessels out here in the periphery. Up here at the top, you can see breaks in the blood vessels where they've had bleeding. There's some here as well. So again, that's the neovascularization of the proliferative type. So hypertensive retinopathy, very much kind of along the lines of the diabetic retinopathy. Its etiology is people who suffer from essential hypertension, acute renal failure. You can also see it in women who have preeclampsia and eclampsia, or if they have a pheochromocytoma. So chronic hypertension, you can see the copper or silver wiring. You can see AV nicking. You may see flame-shaped hemorrhages and retinal exudates. With acute hypertension, like for instance with preeclampsia and eclampsia, you will see arterial narrowing, cotton wool spots, retinal hemorrhages, sorry I got that twice, and disc edema. So again, here is the back of an eye of someone who has hypertensive retinopathies, and again, you can see these new blood vessels being built out here in the periphery. Here's a break or a hemorrhage right here in one of the blood vessels. So definitely not a normal looking eye. Again, you're not going to be able to really appreciate this without the eye being dilated. So the best thing that you can do is make sure that your diabetics and hypertensives are getting to the eye doctor once a year. One of the last things I'm going to talk about is retinoblastoma. And it is a rare cancer that starts in the retina and usually develops early in childhood, typically before the age of 5. And it's very, very, very important in early detection, because if you don't detect it early, the disease can be fatal, or they can lose an eye. So almost half of children have a hereditary genetic defect, and it can also be caused by a congenital mutation in chromosome 13. And so signs and symptoms, when you do a physical exam, one of the things that we do on physical exams with kiddos is you have to get a red reflex. And the problem is kids don't necessarily want to sit still so that you can get a red reflex. And when you're doing a physical exam and somebody who has a retinoblastoma, instead of getting a red flashback of the retina, you're going to get a white flashback, which is called leukocoria. And it's a white appearing pupil when trying to visualize a red reflex. And the kids will sometimes have deterioration of visual acuity. That deterioration of visual acuity, they may start tilting their head one way or the other. They may have a red irritated eye with glaucoma. They may have a new developed squint. They may have some excess tearing. And you have to do imaging such as a CT or MRI. So the diagnosis, the average age of diagnosis is between 12 and 18 months. And so off to the right there, I put the well child check schedule. And so when kids go in for a well check, they get seen at day 5, week 2, 2 months, 4 months, 6 months, 9 months, and then 12 months. So 12 months, by the time they get to their 12-month exam, they've been seen at least 7 times by a pediatrician. So my question is, if we are really getting red reflexes, why is it that these guys are getting diagnosed between the 12 and 18 months? And I would tell you that a lot of people aren't truly getting red reflexes. The other statistic, I've previously read it, I don't know the exact percentage, but it's over 50%. The vast majority of these kiddos are brought in to the doctor by their parents insisting there's something wrong because of a new squint, excess tearing, their suspicion that they have low visual acuity, or they actually saw that white reflex instead of a red reflex, maybe in a picture. So it's very, very, very important, especially if you work in pediatrics, that you get these red reflexes at every one of these well baby checks. So treatment priority is to preserve the life of the child and then preserve the vision. So that may mean that they have to remove one of the eyes in order to save the child. They have been able to do external beam radiotherapy, brachytherapy, where they implant radioactive pellets into the eye, thermotherapy, laser photocoagulation, and systemic chemotherapy. So prognosis depends on early presentation. So it has about a 95 to 98% cure rate with early detection, but if you don't catch an early detection, it can, move outside of the eye into the brain and things as that. Extraocular retinoblastoma, when it has moved outside of the eye, it has a worse prognosis. The cancer spreads to the brain, the spinal cord, the bone marrow, and the lymph nodes. And there is a Developer named Brian Shaw from Baylor University, he developed the computer-assisted detector of leukochordal. And it's a smartphone app that parents can put on their phone to snap a picture to see if a child has a leukochoria. So that's kind of a neat little thing that's available. And that concludes the lecture in regards to retinal disease.